So I'm going to suggest that we just start with some introductions, as some people are still joining us, but it's just slowing down. I'm Jenny Reindorp. I'm Interim Director of Programmes at NHS Providers. Hi, Emma. And I'm very delighted to welcome you to this third event in our new programme, which is Provider Collaboratives Improving Equitably. And it's great to see a mix, I think, of board members on the call. We've got some execs and non-execs, just looking at some of the names in the chat, and those working into the board. The programme is about helping senior leaders working across provider collabs to develop shared improvement approaches which embed a focus on equity from the outset. And we're really delighted to be joining forces with the Q community on this programme, with the support of the Health Foundation, to draw on their extensive expertise in continuous improvement and their community of improvement leads across the sector. And the programme is also supported by NHS England, enabling us to draw on the learning from the National Health Inequalities programme, and also to link into NHS England's renewed focus on encouraging continuous improvement as part of NHS Impact. So the focus of our session today is very much on the role of board members and senior improvers in creating an enabling environment for improvement where equity considerations are front and centre. We know this work is at an early stage in Provider Collab, so we're going to explore some of the practical tools and approaches at use at an organisational level which can support this emerging partnership work, and hope will provide an opportunity to consider how you might apply this within your own context. So without further ado, I'm just going to introduce our speakers for today. Professor Graham Martin, who is Director of Research at the Healthcare Improvement Studies Institute. And Graham is going to set the scene for us on what provider collaboratives can learn from the evidence on existing models of collaboration and what helps to foster high impact alliances. Alice Forsyth, welcome, is Executive Partner at the Virginia Mason Institute, and she has worked with leaders worldwide to develop organisational strategies that really embed inclusion, equity, and belonging at their heart. And Alice is going to share some tools, some very practical tools that VMI have developed, which can help to embed equity into leadership and practice. And then finally, I'm delighted to welcome Dr. Ailsa Brotherton, who is Executive Director of Improvement, Research and Innovation at Lancashire Teaching Hospitals. And Ailsa has also recently been appointed the Improvement Director, the National Improvement Board for NHS England. So congratulations to you, Ailsa, for that. And Ailsa is going to share some of the tools that they have developed to support improvement work across the Lancashire and South Cumbria Provider Collaborative. Before we dive in, just a little bit of housekeeping. This is designed to be an interactive session, so there'll be time for questions throughout. Do please just use the raise hand function or post any questions in the chat, and do also use the chat function to share any thoughts or comments from the work that's taking place within your trust or provider collaborative. And if you haven't already done so, do please introduce yourself and your name and organisation in the chat. And if you are happy to share any reflections on where you think your provider collaborative is in developing a shared approach to improvement, that would be great to provide some context for today's session, whether you feel it's early days, something that's relatively well developed, any thoughts on where you are in your improvement journey across your provider collaborative. It would be great to see those in the chat. So without further ado, I'm going to hand over to Graham, who's going to kick us off with a scene setter on what we've learned about how to make collaboration work. Thanks, Graham.
Thank you, Jenny. So welcome, good to see everyone, and thanks for the introductions in the chat. It's really useful to see where people are coming from. So Jenny said, I'm going to talk a little bit about the background, to some extent the theory around collaboration, but hopefully trying to make that quite applied. And I'm going to try and relate some of that theory and some of that evidence directly to the kind of provider collaboratives that you're engaged in. Next slide, please. So just 4 sections to my work, which I will do my best to squeeze into my allotted 10 or 12 minutes. So a bit about theory, a couple of examples of different approaches to collaboration, because collaborative and collaboration can describe a wide range of different approaches. a little bit about the evidence about whether they work, in what circumstances they work, and how they work. And then, as I say, hopefully some particular thoughts, reflections on how that literature and evidence relates to the kinds of things you're doing. Next slide, please. And next slide, please. So just to put it into context, collaboration is something that's written about a great deal in the academic literature. That first reference there, the first line with a little number 1 at the end, that's probably the key thing that I'll be referring to again and again. The last slide gives you the references, and the slides will be shared with you so you can pick them out. But that first reference is probably the key one because it's a chapter that I've co-written on collaboration-based approaches to improvement in general. So it kind of summarizes most of what I know about this stuff. So it's an obvious place to draw on. But the way that my colleague and I describe collaboration is in terms of networks, and networks of people who come together towards a shared goal to cooperate to try to achieve that. And you can look in the idea of networks of collaborations are explored at all sorts of levels in terms of public services and trying to deliver high quality care and other public services to people. The third way there, in inverted commas, does partly refer to New Labour and the kind of the Tony Blair notion of a third way, where collaboration, networks, cooperation were posited as an alternative to the two traditional ways of organising public services. If you just click on, so that is to say hierarchies, people in bureaucracies telling people underneath what to do and trying to give good public services that way and achieve change that way. Markets being the second way, the idea that competition and market incentives are the best ways to drive improvements, and then networks coming along as an alternative, both of those, trying to overcome some of their shortcomings and say actually collaboration, helping people to view each other as peers, as colleagues, as cooperators, rather than as competitors or subordinates or superordinates, is a better way to achieve change. And click on a couple of times. So collaboration does have some advantages over the other two forms in theory, and it has some weaknesses as well. Next slide. So some of those advantages on the left there are the kinds of things that collaborations can do in a way that hierarchies and markets can't do them. So you can be more responsive, more dynamic than if you're in a bureaucracy, because you're not going to wait for approval from the top down. If you're not viewing other people as competitors or rivals in a bureaucracy, but rather as collaborators, as sharers, then you are more inclined to share knowledge, again, at least in theory. So it could be a good way of spreading good practice, of helping people to work together. And per the third point on the left there, to be creative, the idea that working together, bouncing off each other, sparking ideas gives you much better ways of doing things than, again, working in silos, seeing those people over there as rivals rather than as collaborators can do. On the other hand, collaborations are often fragile, particularly where those other two approaches to organising public services predominate. So it's very easy for collaboration to be put to one side if the people you're being asked to collaborate with, for example, you're also seeing them as your rivals or your competitors for funding or prestige or whatever else it happens to be. They take time to build because they're reliant on trust. You're only going to share knowledge and learn to work with people if you think that they're not going to screw you over, frankly, if you're confident that they're viewing you as cooperators in the same way as you're viewing them as cooperators. And then thirdly, on the right there, actually trying to make this work in practice is quite tricky. And we have this lovely idea of lots of people holding hands, linking together, perhaps singing Hallelujah and Kumbaya, working in a really cooperative way. But actually one of the challenges of collaborations is that it does, all the incentives and all that carrots and sticks operate at that collective level. And that means individually, people can freeload, they can take advantage, they can take out more of a collaboration they put in. And trying to overcome some of those challenges is not easy. And again, it's a long-term process to build that up. So click forward a couple of slides, please. Thanks, Katie. So just to give you two examples of collaboration, and it comes in many, many different varieties. But these two examples, I've chosen them, A, because they're quite well known. So probably people have heard of quality improvement collaboratives. And of course, you're all involved in provider collaboratives, which have some things in common with those QI collaboratives. And communities of practice, people have probably heard the term at least, although again, it's one that's been used in lots of different ways. And I think it's useful to look at these two in turn because they kind of exemplify not quite opposite ends of the collaboration scale, but they do exemplify slightly different approaches to what collaboration is and why it can work and what you can get out of it. So next slide, please, Katie. So quality improvement collaboratives used in a number of different ways, but perhaps the original collaboratives come from the United States in particular. So you've got collaboratives from the 1980s forward that grew up around disease registries, so equivalent to what we might call national clinical audits, big sets of data that a number of different providers put into a big database, and then they use that data to identify unwarranted variation, to identify areas where processes aren't perhaps being implemented in the way they should be, to identify areas where outcomes aren't as good as they should be, and thereby to identify, associations between what you put in and what you get out, to see who's doing well, to see who's doing not so well, and as a means of reducing that unwarranted variation and sharing good practice. And if you click on, please, Katie. So data, therefore, is crucial to their approach, and particularly having credible data sources, so people don't say, oh, the data's wrong, it's not a problem with me, it's a problem with the data. Making sure that the data are fair and seen as accurate, making sure the data are standardized, risk adjusted and what have you, to make them comparable so that you can see how you're doing compared to your peers, but also making sure that the data are used in a guarded way. So you're not using these data, again, as a means of gaining competitive advantage over your collaborators. Rather, they are ways of identifying good practice, weaker practice, sharing knowledge, improving collectively. And alongside the data, those collaboratives have very well-developed feedback techniques, structured ways of interpreting data, structured ways of sharing knowledge between them, quality improvement techniques, and all the rest of it. And that's what's made them, over the long term, next click, please, quite successful, I think it's fair to say. If you click on again, please, Katie, communities of practice. Again, I think people will know the term. They tend to be used, the term tends to be used to refer to somewhat looser collaborations, people coming together because they have a common interest or a common skill. And one of the things that communities of practice, at least in their original idea, are good at is sharing what Brown and Duguid call non-canonical practices. Reference 3 there is a classic example study of a community of practice in relation to Xerox photocopying engineers, hence the picture. And what it really, really emphasizes is that there's so much to being a photocopier engineer, who knew, that's about know-how, it's about workarounds, it's about kind of folk knowledge rather than following an instruction book. And so having a community of practice that allowed people to share that knowledge, share the know-how, the tacit knowledge, the work as done rather than the work as imagined, was really, really important. So these are much more self-forming, bottom-up, or at least traditionally, and somewhat less structured. So that's two slightly different examples of a collaborative approach, both of which have their uses and both of which might be of some relevance to you as people trying to convene provider collaboratives. So do they work? Next slide. The answer, perhaps unsurprisingly, is sometimes, sometimes not. If you look at them, if you look at the evidence base in aggregate, it'll say, you couldn't really say definitively that if you invest in this, you're going to get a cost-effective output. But of course, these are quite complex interventions. They're black boxes. They're not just about trying to achieve improvements in outcomes, particularly communities of practice. They're much more about what people get out of them to improve as professionals and collaborators and practitioners and so on. I think there's some evidence that the longer lasting collaboratives, as I said, for example, the New England, the Vermont, the Michigan collaboratives in the United States, have shown some impacts and impacts on clinical outcomes, Communities of practice less so, but then, as I say, communities of practice are less about trying to impact clinical practice. One more click on this slide. And yeah, it's a lot of it's because these are black boxes. It's about how you do it rather than, and what you're trying to get out of it rather than necessarily whether this as an intervention works or not. And there are good practice guidance of various kinds relating to these interventions out there, such as reference 6. A couple of slides forward, please, Katie, thanks. So what are the implications? I think number one is that collaboration, as I say, covers quite a wide variety of different approaches, and they do have slightly different uses, slightly different applications. And what's best for reducing unwarranted variation between providers, for example, might not be best for sparking creativity. A little bit more on that on the next slide. It can be hindered by these other competing forms, the fact that people are also responsible, accountable to hierarchies, the fact that they might be in quite competitive environments, even in this era of integrated care systems. They might still have a residual sense that there's a zero-sum gain here, and if what they gain in a pathway, others will lose. But equally, just leaving them to their own devices and expecting collaboratives to collaborate on their own is probably not the best idea either. You've got to think carefully about what the goals are, how you facilitate, encourage, nurture collaborative behaviour, and so on. I think one more click on this slide. And yeah, it needs time. Clearly, trust takes time to build. And to make it a routine way of working, and make people recognize that it's here to stay, takes time. So I think you just need one more click, please, Katie, and then this is my last slide. Oh, yeah, these are going to appear by themselves. So these are just some thoughts in terms of that literature about the kinds of questions you might ask yourselves. And I am running out of time, so just to focus on one or two. I think the third one down there, the kind of problem your collaborative is trying to address, is a really important one. So if you're sharing good practice, then it might be that you take the North American collaborative approach. It's about pooling your data, finding out who's doing well, who's doing badly, and then learning from the ones who are doing well. And you'll find that, you know, there's no single best practice site, most likely. Different people will have different things to share, and so everyone can learn and everyone can teach in those kinds of situations. Data are clearly crucial, but how you use those data is going to be really important. And for example, again, if you're trying to level up, if you're trying to reduce unwarranted variation, then perhaps it's individual organization level measures that are most important. But if you're trying to challenge, to address a wicked problem like public health, health equity, then perhaps you need to think about the common measures, the things that you are all pulling towards, the things that will show that as a system you've improved, and thinking carefully about who needs to be involved in that. And then finally, last but not least, really investing in collaboratives, making sure that you know, you're taking care of the administration, you're making time for people to work together, you're taking care of the humdrum stuff, you're making collaboration the obvious thing, is going to be crucial, and showing again that this is a real long-term commitment. So that's it. You just click a couple more slides and people can see the references, but I don't think I'll have time. Oh, no, the references have gone, but the references are in my version of the slides, and I'm sure it'll be possible to share them with you. Thank you.
Thank you so much, Graham. That's a really helpful whistle-stop background tour, really, of the evidence on provider collaboration. And I'm sure our members on the call will really recognise what you've portrayed there about this being a kind of long-term endeavour, where it's about building trust and embedding collaboration as a routine way of working, as well as the challenge that you pose there about how do you ensure time for collaboration isn't squeezed by all the multiple other pressures that everybody's facing, particularly at the moment. I'm keeping an eye on the chat. Do please use your raise hand function or put any comments and reflections in the chat. And while people are having a think, I'm going to just throw to Ailsa, just from your experience, Ailsa, in the provider collaborative, in your patch, whether there's anything particularly from Graham's kind of on those, you know, on the benefits of collaboration and some of the challenges that particularly resonated for you.
Yeah, thank you very much, Jenny. So lots of what Graham said resonated, and I think two that I would pull out is the use of data. So we've been doing some work, which I'll share with you later on the call, about, you know, how we really work together across our provider collaborative, and data is absolutely key if we're not comparing the same. So taking the time to invest in the measurement for improvement and the development of the data dashboards, so that our teams can really learn from each other and understand which part of the work is really delivering the improvements, is key. And the second thing Graham said, which we are absolutely finding, is allowing our teams the time to build the relationships. If you don't invest in the relationship building at the start, then actually you just don't get the sharing of work and the trust between teams to be able to deliver. And that takes time. And I think we often underestimate, and it would be easy to say, this program isn't delivering, let's move on, when actually just a bit more time and continuing the focus of improvement, the results will follow.
Yeah, it's really helpful, Ailsa. I think we had a kind of session on provider collaboratives a couple of weeks ago, where people talked about emerging benefits, and that kind of, you've got to stay the course and hold your nerve and keep going in building those relationships, and not give up too soon, and recognize this being a, like we said, a long-term endeavor. I also took, Graham, the kind of your focus on data and learning from other collaboratives about how important that has been, as something that we might also pick up more in this program, about the different approaches collabs have been taking to that kind of shared data piece. We had a really powerful presentation from Wyatt, which maybe if the team can dig out, we could pop it in the chat, or we could send it in the post-event email on how they're across Wyatt, they're sharing data to look at unwarranted variation. But I know also it's something that you'll also pick up in your presentation. So with an eye on the time, I'm going to now hand over to Alice who's going to give some kind of reflections from all the work that you've been doing, Alice, thinking about how do we make equity an integral part of our improvement approaches when we're working at trust level, but for today, particularly thinking about working in partnership. Over to you, Alice.
Thanks so much, Jenny. Good afternoon, everyone. It's a pleasure to share what we've done at Virginia Mason to embed equity into our improvement culture. And I hope you find some tips that will be useful for your organizations. So the journey to build any organizational culture is really years in the making. And today I'll share 3 of the most important building blocks for creating and sustaining the organizational culture that you want. The first is making implicit behaviors crystal clear and explicit to all stakeholders from board to ward. The second is providing leaders and teams with user-friendly tools to help them embed that equity lens into their leadership and their quality improvement work. And the third is to foster a systems approach that's based on a consistent single management system that all leaders and staff are trained in. So first, we'll begin with making the implicit explicit. And all the behavior models and constructs in this section are taught in induction training for board members, staff, consultants, and leaders. And they're reinforced in new leader training as well. So when we think about organizational values, this is something that most organizations have. If your organization does have identified values, do you also have behaviors to make it clear how each value should come to life in the organization? This can be beneficial because clarifying what each value means in behavioral terms really does help staff and leaders know what's expected. This particular set of values and behaviors is from Virginia Mason's 10-hospital system in the Pacific Northwest of the United States. And we actually had our board chair was part of the team that helped develop these values, and they were really integral to the merger that we went through a few years ago. It was a great way to unify the organization at that time. And you can see that we included the value of inclusion, which was new for us. So a second way that we've made the implicit explicit is to directly tie behaviors to the organization's management system, as you'll see on the next slide. This helps support our continuous improvement efforts and really does align all of our work throughout the health system. So respect for people is a pillar of the Virginia Mason management system, and these are the 10 foundational behaviors that help us engage with patients, other staff, and visitors in a consistent way throughout the organization. And this construct is mentioned daily in the organization, and it's part of every continuous improvement event that we do. By the way, you can access the full tool with all the behavior definitions via the QR code in the bottom right corner. A third way to be clear about the behavior you want to drive organizational culture is on the next slide, and that is to identify reciprocal agreements or compacts for various influential groups in the organization to ensure that they know what's expected of them and they know what they can expect from the organization in return. So you can see that we've implemented compacts for our board, leaders, and our physicians. And these are so much more than just a piece of paper. The development of each of these really spurred and sparks dialogue about expectations for each of these roles, and leaders use them to anchor conversations, and our board uses it to anchor their conversations on a regular basis. They're used in recruiting, performance evaluations, and simply to start meetings to connect what's being discussed with the organizational and individual responsibilities. So on the next slide, I wanted to mention that we clarify what's meant by health equity up front. So we really want to make that explicit as well, that what we mean by health equity is that everyone has a fair and just opportunity to be as healthy as possible, and resources are customized to individual and group needs. And we can see that when we focus on equality, we get sameness, as shown in the top image, where some people may not have what they need. Whereas when we focus on equity, we are taking into account each person's unique differences, and we're able to identify and provide the resources that each individual needs based on their situation. So that's a preamble to some tools that we're going to talk about next. So the constructs of psychological safety on the next slide and our inequity waste wheel are critical to innovation. Psychological safety enables people to feel they can be open, express curiosity, and share ideas for improvement. And it's a team construct that leaders can influence through the behaviors shown on the bottom left. And I've even heard chief executives at some NHS trusts say that their board can even demonstrate psychological safety and really create that space to have safe conversations at the board level as well. On the right, we see Virginia Mason's inequity waste wheel, which is similar to other waste wheels that you may have encountered in quality improvement, except this one that we developed a few years ago focuses dialogue specifically around the types of inequities that can occur in any organization. So the three inequity types shown in violet are often experienced by people without power and privilege. Those are underrepresentation, mistrust, and access barriers. And the ones shown in blue may be displayed by people with power and privilege, often unintentionally. To access the complete resource that includes a set of equity impact analysis questions, you can scan the QR code in the top right of the screen. Now we'll move on to some additional tools that leaders and teams can use to systematize equity into their organizational culture. So the first one on the next slide is the equity pause. This comes in two forms, a planned equity pause or a spontaneous one. These are simply an opportunity to stop a conversation and briefly focus on the equity elements that may be occurring. For example, our transplant department used this technique to discuss the root cause of why so many people were on the transplant waiting list. The leader there encouraged her team to look at the inequity waste wheel that we saw in the previous slide and identify the inequities that might be occurring for the people on the waiting list. And this was a planned form of an equity pause. And through the discussion, the team determined that there was an access barrier for some of the patients because they weren't able to afford to pay for the dental treatment needed to obtain the dental clearance for their transplant surgeries. The transplant surgeons looked at the issue and found that that dental clearance could be removed for some patients. And this really enabled them to proceed with the transplant surgeries that those patients needed. Equity pauses are also used on a regular basis by our executive leadership team. What they do is at the start of all of their meetings, one of the executives will conduct a discussion and they'll have selected a discussion question that's focused on an equity concept that's relevant to a topic on their agenda for the meeting. And this has really helped them center their equity in their conversations. These pauses are also a standard part of all of our quality improvement events. And then spontaneous equity pauses can occur in the moment when somebody on the team notices that there may be an issue related to equity. And this can occur more and more often when they do feel that sense of psychological safety. So the next slide shows a tool that we developed to help leaders make it easier to embed equity pauses into their team culture. These are called equity huddle cards, and you can access them via the QR code there. There are 9 topics. We list 3 here, varying from equity and equality, diversity, inclusion, as well as anti-racism, implicit bias, and the others that you see here. Each of the cards have 2 to 3 questions that the teams can discuss in a 7 to 10 minute huddle to connect their work to the topic at hand. So it's a very similar construct to what our executive team is doing. And it's an easy way for leaders to conduct these conversations with their teams. And soon they realize that people on their team want to start facilitating the conversations as well. So it becomes embedded in how they do their work in their department every day. The last tool we're sharing in this section today is the Equity Learning Pathway, which is on the next slide. This is a rich resource with 8 sections that are listed here, and you can see similar topics around the learning pathway, similar to those that are in the huddle cards. Each section is a menu that has several readings or videos or podcasts or activities that help teams learn and become familiar with the concepts and how they may arise in a healthcare setting. And to use this tool, the team simply identifies a cadence for their discussion. Will they have them weekly or biweekly or monthly? And then they use the tool in a self-directed way. So they select the item or the items that they want to discuss, and each person may select their own, or they may choose to read or watch the same item and then discuss it as a group. And then they determine how they want to apply what they've learned. And the last two sections here are really for teams that want to learn how to teach or use these concepts in improvement events. So the last area that we're going to talk about is the importance of fostering a systems approach to embed equity across an organization. The next slide shows that what we mean by a systems approach is developing that shared mindset and those routines and behaviors that we've talked about earlier, and an infrastructure that incorporates the user-friendly tools that are in the center here to support the desired behavior and drive safer, higher quality, more equitable care and experience for our patients. The management system visual on the right shows the respect for people pillar, which aims to create a safe and respectful environment and increase reliability and effectiveness, including more equitable care. And we really talk about including patients as partners, as well as engaging individuals and teams in the agreements and behaviors that we've talked about earlier. And the additional point that I wanted to make is on the next slide about including patients. As you know, this is so critical to impactful quality improvement. And we wanted to just leave you with one example that we're currently working on with the NHS, which is partnering with colleagues at the PSC to support mental health trusts across England that are endeavoring to implement quality improvement in support of the Mental Health Act reforms. And co-production is really at the heart of this program. In fact, our steering group is about a third to half lived experience advisors. And we have lived experience practitioners embedded in our core delivery team as well. And this has really helped remove power differences and surface some systemic issues that sometimes leaders and board members have a hard time seeing. So it's been just extremely beneficial to have this lived experience perspective so we can tackle these tough issues in concert with people who have lived through them. So I'll leave you with a couple of questions to try to progress toward action. And so I really encourage you to think about what is one tool or technique that you learned about that you'd like to begin using when you return to your organization? And what's the first step you could take to implement that tool or technique? So I'll leave you with both of those questions. Thanks so much.
Thanks so much, Alice. Really rich insights there. I have to say, I particularly like the kind of equity pause as a tool, because I think it's a real reminder that unless we stop and think consciously about equity, so many of our ingrained ways of behaving and thinking our systems and processes could be driving increased unfairness, however unintentional that might be. So it feels to me like a really powerful and simple tool. And also just that underlining the point that, psychological safety is key if people are going to have these conversations, and what do boards and leadership teams need to do to create that environment. I'm keeping an eye on the chat. Do feel free to come in if you've got any thoughts and questions in response to what Alice said, and any thought about a tool that you might take away. I'm also just clocking Mahmood just raised in the chat. Are we talking about quality of opportunity or outcome experience? And Alice, I wonder if you might just speak to that point about the kind of scale of the ambition when you're talking about the equity work that you've been doing.
So yes, definitely both. So equity in terms of equitable opportunities, as well as equitable care outcomes and experience. Definitely. It's what we're looking at in all the work that we do at our organization, as well as with our clients.
Thanks, Alice. I wonder if you could also just say a bit about how you've worked with boards as leaders, as whole leadership teams, to get to that point where people are really, it does feel that this is an embedded part of the way that the leadership team operates, and what that work has looked like, because obviously the tools can help, but I just wonder about the kind of whole team approach in terms of kind of OD, kind of deep OD work that underpins this, particularly people having to confront some of their own biases and prejudices in order to do this work really authentically and well.
Question. So our board did a 3-day retreat focused on this topic, where they brought in speakers, they did some self-reflection activities, and this was a precursor to us developing a full strategy related to equity, diversity, and inclusion. And so the aim was to really help prepare the board. And then following that, our executives and our leaders had more than 20 hours of training. Again, self-reflection opportunities to understand, have a shared language around equity, inclusion, diversity topics, and then connect them to strategy. And so we now have a quite well built out set of strategies around these topics. And so they're discussed on a regular basis now because they do connect to organizational strategy.
That's really helpful, Alice, isn't it? Because it's how to see it not as an add-on, but as genuinely an embedded and integral part of all that the board does, including its, thinking about its strategic priorities. There's lots in there that I think we'll want to share more widely. So thank you so much, Alice, for that. Just mindful of time, I'm now going to just hand over to Ailsa, who's going to speak specifically about the work in your patch, Ailsa, across your provider collaborative and wider system on shared approaches to improvement with equity front and centre. So over to you, Ailsa.
Okay, thank you very much, Jenny. And while we're just waiting for the slides to appear, I want to start by really thanking all of the leaders across our provider collaborative. So if we just move to the next couple of slides, you'll see that this really is a village of improvers. So we have our collaborative here. So it's the Lancs and South Cumbria Provider Collaborative Board. And actually the way we've structured ourselves to work is we've got our chairs and chief executives on the Provider Collaborative Board, and we've had the support of each and every one of them here. So if you're in a non-executive director role or a CEO role and you're thinking, what can my contribution be, setting the vision for our provider collaborative around the focus on improvement is what this team have done for us. And if you just move on a slide, we actually have, for our structure, we have a coordination group, which is where lots of the work actually happens. So we have each of our professional groups around the table for our coordination group, and we need to update this slide because I've subsequently joined when we had a conversation about how we really embed improvement into it. And actually one of the things that I think we're starting to really understand is the contribution of everyone in terms of really creating that, building the vision and a compelling vision that our staff can really work with us on. So if we just move on in the presentation, I just want to take a moment to recognise the personal contribution of Kevin McGee in this work. So Kevin was our lead CEO at the time, and Kevin really understood that systems don't just work, they have to be planned, built and designed. And actually what Kevin had was the vision around the provider collaborative being really the engine room for improvement. And one of the questions Kevin asked us when he first took over the role was to really work together as a group of improvement directors across our patch to really understand how we could work together in the way that we've heard from Graham, the importance of outlining collaboratives. What could we achieve differently if we worked in a very collaborative way and we brought improvement science as the way that we were going to really focus on some of our challenges around our performance and delivery? So what we did was we got together as a group of improvement leads and we shared what we were doing already. So what we found when we did that is each of us did have a different improvement methodology in our organisations. But what we learned through that workshop that we held together was actually the core elements of improvement are the same. And that's really evident in NHS Impact, isn't it, when you look at the 5 elements that they've determined. So what we wanted to do in our provider collaborative was really understand how we could create a framework where we could come together, we could use different improvement methodologies depending on what we had in our organisations. But the framework in which we came to work together was really critical for us. And you can see here that we wanted to really work to understand. We spent time, and we do still spend time when we work together across our collaborative, in understanding the data. So really picking up on what Graham was saying to us about the importance of really understanding the data at the outset. And then we move through a co-design, deliver and a sustain phase with the work that we do. And actually what we are now building is we're testing engineering better care across our provider collaborative, and over recent months we've been extending this to be across our ICS, because one of the things we all recognise is obviously patient pathway journeys extend the entire system, not just the organisations who are part of our provider collaborative. So what we're starting to see here is a really different way of working, and I was struck by Alice's presentation on the importance of systems and system leadership, because that's what we're really talking about here. So I just wanted to now give you an example of, and it was great, Graham, that you referenced the collaborative. So this is an IHI Breakthrough Series collaborative that we're running across our provider collaborative. And really, I just wanted to share with you here the benefits of working together. So we knew, and we looked at our data, and actually across our acute providers in our collaborative, 3 of us were in the lowest quartile of performance for length of stay for fractured hips, and 1 of us was in the 3rd quartile. That's not where any of us want to be. And what we did was we looked to see where the best practice was. So what both Graham and Alice have talked about in terms of learning from others was absolutely critical for us. And we didn't take part in the national collaborative. So we looked at the change package, we looked at the information, and we had one of our improvement leaders. So it's actually Stuart and my team who's leading this on behalf of all of our acute providers with our clinical lead. So Steve Canty, who's the clinical lead, brought the clinical teams together. Each one of our organisations support the local team in terms of the improvement expertise, and you can see there that actually in a short amount of time we've seen a really significant reduction in our length of stay for our fractured neck of femurs. And actually we are wanting to build on this now as a model, because what we've really understood in Lancs and South Cumbria is if we don't work very differently, we won't have enough improvement science expertise and resource. So instead of all doing it individually, we're now often, where it's a priority for all of us, we're doing it once and doing it together. And then in terms of how we create across a provider collaborative, the conditions for improvement to be successful is something that I just wanted to share with you. I'm not saying this is the only way to do it. There are lots of other ways, and I'd be really keen to hear from any of you working in your provider collaboratives about how you do this. But one of the things I learned when I was based in David Dalton's organisation from Lloyd Provost is around the real importance of creating the conditions for improvement to be successful. So this is the way we do it. We are keen to learn from others if there's better ways of doing it. But for me, this is one of the things that has stood the test of time. So if we just flick through the next few slides, what you'll see here is this is a framework that really understands the context and the factors you need to have in place for improvement to be successful, and it gives you a score. So you can see that if your project is only scoring 25 out of 49, the project really doesn't stand much chance of success, and you might want to deploy your resources elsewhere, or you might want to create the conditions for the project to be successful. So the work that we're doing now across our provider collaborative really focused on frailty and redesigning the whole of frailty, and the teams are meeting today. I've spent the morning with them, and we're back tomorrow with our chief execs and the executive leads from our provider collaborative to really showcase how far we've got with the work and what we want the next steps to be. You'll see on the next slide that we've managed to move that from a score of 112 to a score of 126. Sorry, the numbers have just gone out of line there. And actually what that means is, as a team, we know where we need to focus our efforts. So for example, in this programme of work, we identified data which was going to be one of the things that limited our ability to be successful and to demonstrate success. So we have invested as a team in developing a dashboard for frailty. So when we did our understand phase of the work, we recognised that we didn't have the data at GP practice level. So actually we know how many patients were frail, we know the low percentages that had a frailty assessment and a care plan in place. but actually we didn't have the data that we needed. So we invested in this programme of work to really make sure that we've got that data, and that's something that we are going to share and now launch across our provider collaborative. And actually, I think just sort of looking at then how we build the equity lens into our work, one of the things that we're really mindful of, and Alice has said quite a lot of this, so I won't repeat what Alice has said, but we design our improvement work through the lens of actually where do we have the health inequalities across Lancashire and South Cumbria. And you can see here from this train line illustration that if you live in Windermere, which is a beautiful part of the Lake District, you have got a much higher life expectancy than if you live in central Blackpool. And actually what we're trying to do is use some of the equity approaches, as Alice has described, to really design our improvement to reduce those health inequalities that exist across Lancs and South Cumbria. And actually, this is very similar. It's a different image. It's not bikes, but actually you can see here the difference that we actually start to build into our work when we take that equity lens, and really trying to make sure, as Alice has said, that everyone gets the support they need to be able to access the care that they need when they need it. And really what we're trying to do is work with our health population management partners and our academy to really design our improvement work differently. So through the lens almost of an IQI approach, so that we're really focusing on those inequalities from the design stage at the outset of our work. So just to finish off, I wanted to just sort of share with you some of the work that we've just started over the last few months, which is, so we're trying to build a programme of improvement work across our provider collaborative. This is one that we're particularly excited by. We are taking part in the IHI and NHS England Core 20 Plus Accelerator site, and it's starting to really help us to design very differently the improvement work that we're doing. So we've set ourselves an ambition. We're focusing on cancer in this work initially, and what we're doing is setting ourselves the ambition of really removing those inequities to access of care, and that is something that we want to build into all of the programmes of work that we deliver. And then just to finish off, what we are trying to do in our collaborative is really shift how we plan and deliver care. So for those of you that have worked in provider organisations, you'll be very familiar with the protect, manage, recover part of this cycle, where we really do, when patients are admitted to our hospitals, really focus on treatment plans and how we focus on recovery. What we're trying to do, which is why we're working with our ICS partners very closely, especially our primary care colleagues, we're trying to really shift the focus so that we are predicting and preventing some of the illness that we currently see across our patch. So we really are trying to make sure that we prevent where possible, have earlier detection, so that the treatment that's needed isn't as aggressive, especially for cancer. So we know right now that patients are accessing our cancer services at stage 3 and stage 4, and we want to really, through the work that we're doing on Core 20 Plus, move that to a prevention and an early detection, so that if patients are accessing our care, they're accessing it much sooner with a stage 1 or stage 2 cancer. So in conclusion, I just wanted to finish by saying the one thing that I think we've learned through this work is the importance of leadership and relationships. And we're doing some work with Cambridge University. Some of you may know Professor John Clarkson and the work that he's done in partnership with the Royal Academy of Engineers and the Royal College of Physicians and the Health Foundation around actually what does it take across organisational boundaries to really re-engineer and redesign care differently. And the one thing that I've really learned from working with John and the team is that much of the improvement work I've been involved in up until recent months has been focused on process improvement. And actually, when you expand out beyond an organisation, what we're really looking to do is to really bring systems thinking and systems engineering into the way that we do our improvement work through that equity lens that we've talked about. So we're just going on an exciting journey at the moment with our colleagues in Cambridge to really think about actually, how do we take that systems awareness and systems knowledge to turn it into something really different, so that we skill up our leaders to become system leaders rather than organisational leaders. And we're on a journey to create a faculty across our provider collaborative board of clinicians, improvers, operational leaders who can really lead this work for us to really redesign something very different for the future.
Thank you so much, Ailsa. Another inspiring presentation, just to see how much energy and momentum has already been created around your frailty work, and to see the opportunities in everybody's sites is fantastic to see. And I think so much to share from what you've done. Again, do encourage you to come in the chat, or to raise your hand if you've got questions or reflections from your own experience. Ailsa, I just was also wanting to kind of draw out from that focus you said there around the leadership piece, and if it's focusing beyond kind of process improvement to really say, no, this is a really new way of leading and behaving. What you found has helped so far with the boards across your provider collaborative about getting that kind of alignment about this is the kind of change that's needed? I mean, you spoke about Kevin's vision and, you know, what kind of profound impact that has had. Is there anything else that you would say has particularly helped at board level in getting that kind of, that buy-in, that this is what you're all aiming to, aspiring for?
Yep. So I think one of the things that our provider collaborative board did, Jenny, was to ask David Fillingham, who some of you will know is a chair now across our patch. He's the chair of Lancashire LSCFT, which is actually really helpful. So what David did for us was a review of what does the provider collaborative need to do to be able to really adopt improvement. And David made some recommendations which we are very happy to share with people. But actually what that said was, what we need boards to do is adopt an improvement approach. So task the quality improvement leaders to work together with our OD teams and our finance teams and wider teams to really make sure that this is a shared vision and we work on this together. The other thing that David suggested was that we do some work to really capture and become a learning system, so that actually we learn together from things like, the CQC feedback, things like our assurance programs. So we've started to really have those conversations across the whole organisation. And I think one of the things that we've seen, which has been incredibly helpful, certainly from an improvement director perspective, is that our executives and especially our chief executives are now starting to speak with one voice. So we had a brilliant presentation on leadership in one of our Engineering Better Care sessions from the CEO in Blackpool, and Trish came along and spoke about the importance of personal responsibility in leadership. But she stood at the front and the first thing she said was, I am speaking to you on behalf of our provider collaborative and all of our chief executives who are committed to this programme. So that's been incredibly helpful. The second thing we've had, Jenny, which has been just brilliant, is the support of every single one of the chief executives and our medical directors, nursing directors, etc. So the board members are all behind this, and especially the executive teams. And I think in terms of what good looks like, Alice was talking about, the board and the executive team taking time out. Our executives are very supportive of the work. So we've got a session tomorrow where we're reporting the work, and we've got at least 2 or 3 executives from every organisation in our provider collaborative coming to support their teams. And each one of them appointed an executive sponsor. So it's that kind of support that makes it easy then for us to have conversations about the barriers that we're experiencing that we may need their help to overcome.
Yeah, really fantastic. Thank you, Ailsa. And that is definitely a theme that was picked up in Alice's presentation about that time for boards to really do that OD work and the engagement. And Mahmood, do come on in. Lovely to see you.
Hi, I hope you're well. Thank you for the session so far. I just want to pick up, Ailsa, on your point, and I'll declare an interest because I'm a non-executive. I find it a little bit frustrating, if I'm honest with you, about the interchangeability of the word board and exec team in this. I think, so for my trust, we're part of WIAT, so that's West Yorkshire Association of Acute Trusts, which has been a very functioning provider collaborative before a lot of the system and place changes and continues to be. But I think what's happened with system and place, I think what's happened with provider collaboratives has led to far more partnership working outside of those formal models as well, which has been fantastic. But the problem I see, and it might not be the place everywhere, is executive members of the board, and indeed the chair, for exactly the reasons, Ailsa, I think you gave right at the beginning of the presentation, get dragged into this stuff, positively, I don't mean negatively, to be formally part of partnership working, place system, provider collaboratives, the lot. Non-executives don't. And I think it creates a bit of a tension whereby in my view, great place-based working, great provider collaboratives are where you don't necessarily do the right thing for your organization, but you do the right thing for your population. And I think that can be at risk of being in conflict with the role of the NED, which is about your own four walls. Now, I'm very outward looking, and I find it quite frustrating that I'm not part of this. So and I see the execs going off to here, there, and everywhere. But I think that distinction between is the board joined up on this and is the exec team joined up on this, I think that for me isn't the same thing. I just welcome comments.
Yeah, Mahmood, can I just say that's a really, I just was about to ask actually, how have you got NEDs as well as execs engaged? And it's I think it is a really important point that you're flagging on, one that NHS providers has also been thinking about in our wider work on provider collabs, because the challenge of having that NED oversight and assurance piece is very challenging, given the range of complexity of partnerships and also the conflicting accountabilities. But I'm just going to hand back to Ailsa for how that's played out in your patch.
Yeah, Marie, that's a great question. And we've had those conversations around how do we make sure that we've got enough non-executive director involvement. So we've been very fortunate at Lancs Teaching that two of our NEDs, when we first started our improvement work, actually became our non-executive sponsors of the work. They've both got a great personal interest in it. And then as we've gone forward, what we have done is we have involved the non-executive directors in the work. So one of our non-exec directors has got a brilliant background in industry, and she's joined our think tank. So one of the things I haven't talked about is the structure that we've put in place. So we've obviously got our provider collaborative structure, but for our improvement work, where we're trying to do this across the system and across our provider collaborative, it's largely driven at the moment by the provider collab. What we've done there is we've basically set up a think tank. So we've got a steering committee, so that's at the top. Then we've got a think tank and a do tank. And the reason we've done that is when we looked at the evidence, it's not that strong for how you do improvement work across a whole system in a way that I think we've got the body of evidence. And I'd be interested in Graham's point. You may disagree, Graham, and send me in the direction of the evidence if we've got it, but I haven't been able to find it. So what we did was we said, actually, what do we need? We need to learn as we do this, because there will be some key things that we potentially don't get right, and we need to learn from where we fail. So what we did do was identify who we wanted on the think tank with us, and we thought that would be a great space for our non-executives to get involved in terms of having the oversight, providing the advice. And Trish, our non-exec who's involved in the work, actually comes to the workshops, and she's just brilliant. She's had some great conversations with our primary care colleagues. She's been able to then feed back to other non-exec directors across the whole system, not just in our organisation, some of the work, and she's actually become a real advocate for it. I'm sure she wouldn't mind me sharing that with you all. So I think there is, though, I'll take back your question, because I wonder whether one of the things I'm really keen that we do now is actually write up the work we're doing so that we can share it. But we're really keen to learn from other provider collaboratives too. So if you're doing anything in this space that we're not, I'd really like to hear from you. And I just wonder, Jenny, whether there's an opportunity to write up some of the learning from all of us that are working across our provider collaboratives to really do this work so that we can share it with others. And the role of the non-executive, I think, will be key in that.
I think that's absolutely right, Ailsa. I don't know whether, Mahmood, you want to come back on that?
No, I agree. I just think I'm connected with other NEDs through other means, but I don't feel I'm very connected with other NEDs in my system or across my provider collaborative in any way, shape or form. In West Yorkshire, which is always touted as being one of the best, right? So I think that feels to me to be a bit of a gap. But and from my personal background, I work for Lloyds Banking Group. I'm a customer experience professional, which is for me is the flip side of so Alice, we've deployed Virginia Mason within our trust, and for me there's very common language between the stuff I'm used to and what the organisation's doing. We don't all have common improvement methodologies across our system and across our provider collaboratives, which makes it problematic around that single system of management that you described. So there's lots of learning. That's the flip side. There's lots of learning from each other, but I think we're all learning that you need to have a common methodology and a common measurement framework to do this stuff well. And I think we could have got there a lot quicker if Neds like me that kind of do have an inkling as to what this stuff is all about could have been involved a little bit earlier. But I just think we're the sort of forgotten tribe. Tribe's my favourite word for the NHS now. Forgotten tribe within the NHS that I don't think's been connected enough outside of our four walls in the way that other populations have.
Yeah, thanks, Mood. I think it's such an important point you've raised. I'd like to think not forgotten by NHS providers, because I think governance is really one of our kind of hot topics here. And there's a couple of things we have in the past run sessions. I know there's only one part of it on the NED role for provider collab and provider collabs. And we have got a piece of work that the team is working on different governance models that does also look at the role of NED. So I might just follow up with you if that's all right, because perhaps you might just take a look at that for us to see if we have actually kind of picked up some of these issues. And I think there's something more for us to reflect on what else we could do around the good practice sharing and learning on this. Ailsa.
Yeah, I was just going to make a similar offer, Jenny, to take back, and that's great feedback, to take that back to the new National Improvement Board. So I do know there is a session being planned for chairs, and no doubt there will be multiple sessions continuing for CEOs. But if it would be helpful, I will ask if we can also make sure that there are some sessions for non-exec directors and how we really best, utilise your contribution to NHS Impact, because it will be critical to success, won't it?
Yeah. It's a great shout. Thank you so much, Mahmood, for coming in on that really important point. I've got an eye on time, so I'm actually just thinking if there aren't any other kind of questions or reflections. I did also want to have a chance to just pull some threads together and do some shameless plugging for what we've got coming up on this programme. So can I just start by thanking so much Alice, Ailsa and Graham. Really, really appreciate your time today. This webinar is something that we will be an output that we will share across our provider collaborative networks, also with our improvement networks, and also we have lots of connections with health inequalities leads across provider collabs and trusts, so we will be sharing it widely. And I think there's so much content from all three of your slides that we will want to pull out and get into bite-sized chunks for board members. So thank you so much for your time when I know things are so busy. Just in terms of some headline themes, if I might dare to try and draw out a kind of few key messages, we will try and write them up afterwards, but I think from Graham, that focus on the time needed to build trust and embed collaboration as a way of working, that being a long-term endeavour. Ailsa, I loved your kind of doing it once and doing it together, so that opportunity that provider collaboratives really offer to be the engine room of improvement across systems. And there's just some fantastic examples you've given of that's happening in your patch, but the importance there of system leadership and how that is different from kind of process improvement at trust level. And from the conversation with Mahmood, how do we make sure that is the whole board fully engaged? And then Alice picking up that theme about how do we ensure that equity is really thought about right from the design stage, as you said, Ailsa. So thinking about some of the tools that can help to make that mindset shift to really embed this as part of the day job, as part of the daily work, into routines, behaviours, and our infrastructure. And I think your point, Alice, that psychological safety is also a key bedrock to this if it's really sometimes getting in some difficult territory and uncomfortable conversations about people's biases and blind spots, and where people need to be challenging themselves and colleagues to really think about equity from the beginning. So thank you very much to everybody for coming along. We're just going to post into the chat a quick evaluation survey. I appreciate time is tight, so if you don't have a chance to fill in the survey, which it would be fantastic if you could, please leave any comments just in the chat now about what you found helpful and what we might do differently. And if you're happy to keep in touch with other attendees from today's session, do pop your email in the chat. And just to plug where we're going next with this programme, we have a session in December that's really focusing on the challenge around improving waiting lists equitably. So we're really applying this lens of improvement where equity is front and centre into that immediate operational priority for our members. So really encourage you to join us then. We will have further peer learning sessions in the new year. So again, we really welcome your ideas and suggestions for where we can most helpfully focus next. Obviously, the role of NEDs is one thing we will take away from this. And there will also be workshops that we are running for a smaller group of provider collabs with the Health Foundation and Q community to dig in greater depth into how we can support this work. And if you'd be interested in joining those workshops, do contact a member of the team. So hoping I'm giving you a couple of minutes back at this point. So we're just due to finish at 3:10, but thank you again, everybody, for coming along today. There's lots of links in the chat, so hope you'll have a chance to take those away and apply some of the learning to your own contexts. But thank you once again.